During this episode of Making the Rounds, Failure is Not an Option series, we will be discussing heart failure, and the failure to optimize medical therapy is not an option. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in, and if you're a regular listener, welcome back. Joining me today on Making the Rounds is Dr. Radha Gopalan, heart failure cardiologist at Banner University Medicine Phoenix and medical director of advanced heart failure at Banner University Medicine Phoenix. Thank you, Dr. Gopalan, for joining me, and welcome to Making the Rounds.
Thank you, Bridget. I'm very excited to be here and share some information with the audience.
Dr. Gopalan, how big is the heart failure problem in this country, and what medical therapy is recommended?
In the United States, heart failure is a big problem, and it's a growing problem. It does not only have a clinical connotation to it, it also has an economic burden to the country. By 2030, it's expected to cost approximately $40 billion to care for patients with heart failure. The current population and estimate of existing heart failure population is about 6.2 million in this country. And out of those, every year, we are documenting approximately 380,000 deaths related to heart failure. And if you look at heart failure, we traditionally as heart failure cardiologists separate heart failure into heart failure with reduced ejection fraction, meaning left ventricular systolic dysfunction, which is the ability of the heart to pump effectively is reduced, versus heart failure with preserved ejection fraction, where we call it a diastolic dysfunction, which means the ability of the heart to fill with blood in order to eject is impaired. No matter which one we look at, it's about 50-50 in resulting in heart failure burden in this country.
In comparison to other health conditions, how serious is a heart failure diagnosis?
Let me just compare that to cancer. When we hear the word cancer, we worry about the fact that it's a killer disease, which is true in many cancers. So how does heart failure compare to cancer? From the time heart failure is diagnosed in a patient, there is a 50% chance of surviving 5 years. That means 50% of those patients who are diagnosed with heart failure, from the time they are diagnosed, irrespective of whether they are on medical therapy or not, they have a 50% chance of living 5 years. When you compare to cancers, there are only two cancers that beat heart failure survival. Only lung cancer, which is worse than heart failure mortality, and then colorectal cancer. Those are the two. But most often, breast cancer, prostate cancer, bladder cancer, and those, they tend to have better survival, irrespective of being a cancer diagnosis. So heart failure compares favorably with regard to cancer, with being a burden and a mortality with regard to survival and death. So it's a big problem.
And when we look at the consequences of heart failure, what happens if strategies are not optimized?
So in heart failure, if strategies are not optimized, so as I mentioned, there's a 50% chance of surviving 5 years after you are diagnosed. The opportunity for the patient who is diagnosed with heart failure to move into that 50% that survives more than 5 years is enhanced if you optimize medical therapy. So what we want to do is reduce the number of people who don't survive more than 5 years and want to push them into the cohort of patients who survive more than 5 years. So if patients are not optimized on guideline-directed therapy that is recommended by the societies, and in the United States it's American College of Cardiology, American Heart Association, and Heart Failure Society of America, who have recommended guidelines as to how to treat these patients. If we do not optimize the medical therapy, the chances of more patients dying within 5 years is high.
Dr. Gopalan, can you share with us some of the key updates for the medical evaluation and management for heart failure?
In heart failure, we have progressed so much in the past 15 years. Tremendous research and advances have been made, especially with regard to medical therapy. For example, in 2013, 2014, we studied one of the novel drugs called SGLT2 inhibitors, which was originally started off as a diabetic medicine, which have now recently proven to be an excellent drug for cardiac patients, especially heart failure. Either heart failure with reduced ejection fraction, or now considerations being given for that to be used for patients who have heart failure with preserved ejection fraction. And the important thing to consider here is, in heart failure, it is not unusual to find other organ failures, such as renal failure and liver failure. And these patients, especially the SGLT2 inhibitors, which comprises of a fourth pillar of heart failure therapy, has been a robust drug rapidly advancing for indications in the heart failure population, including patients who have baseline renal dysfunction. Right now, only caution is if the GFR or glomerular filtration rate is less than 30, we don't use it, but those indications might expand even to those patients pretty soon. But that's one of the rapid advancements in medical therapy.
What are some of the early initiation of heart failure therapies, and can you share some clinical data surrounding that?
Yeah, the beta blockers, ACE inhibitors were studied in the 90s, and then we had a mortality benefit for beta blockers in the range of about 34%, and ACE inhibitors in the range of 25 to 30% mortality benefit, and they were well adapted in heart failure population. Subsequent to ACE inhibitors, angiotensin receptor blockers, and beta blockers, we have added what we call aldactone or MRAs that have a similar additional mortality benefit in the range of 14 to 18%. Now, by 2015, we have recommendations that came out and said that patients should be transitioned to angiotensin receptor neprilysin inhibitor medications. A medicine by the name of Entresto has become more popular and has replaced patients who have been taking ACE inhibitors because it had improved mortality benefit compared to ACE inhibitors alone. So those mortality benefits, they are added benefits on top of each other. Therefore, there's tremendous benefit in keeping patients in all four medications as opposed to having them in 1, 2, or 3 medications.
Have there been any advancements for surgical intervention for heart failure patients?
So the surgical interventions for heart failure have been advancing in the recent past. You can divide them into 2 types. One of them is electrophysiology-oriented mini surgical interventions, such as we call that device therapy, meaning smaller devices from an electrical perspective. So there have been devices such as biventricular resynchronization device, meaning these are devices that allow the heart to contract and eject blood in a synchronized fashion, because in heart failure patients who have what we call left bundle branch block, the contraction of the left ventricle is not synchronized and coordinated. So in order to correct that, we implant what is called biventricular pacemakers. The implantable defibrillators have been, since early 2000s, a mainstay of treatment for patients, because heart failure patients with the diagnosis of heart failure have a 7-fold higher risk of having sudden death. To prevent this, we implant what we call implantable defibrillators in these patients. That's another device therapy from an electrophysiological perspective. Thirdly, and recently, there have been an additional device called cardiac contractility modulation, which is a device that delivers a small electrical impulse in the refractory period of the action potential of the heart to enhance the contractility. As a result, this has shown to reduce hospitalizations, and there is some suggestion and signal of this device therapy having genetic modification in heart failure patients. That remains to be proven. However, there are some early signals that shows that there may be genetic benefit by having the CCM therapy. Those are the electrical therapies that are used in patients who are class 3 heart failure. If you look at other device therapies, what we call left ventricular assist device therapies to improve survival, that can be then divided into temporary versus durable devices. And that has also improved with regard to the technology of the device and tolerability of these devices in patients, and minimizing side effects of these devices. At Banner University Medicine, we are the only center in Arizona who have total artificial heart. No other centers in this state implants total artificial heart for those patients who require biventricular support. We implant these devices as a bridge to transplantation.
Dr. Gopalan, heart failure can be complex and difficult to manage. When should a primary care refer to a heart failure specialist?
Thank you. And I think the easiest way of recognizing this is to separate heart failure and advanced heart failure. So what does advanced heart failure mean? Most of the time, as physicians, we fail to recognize when a patient transitions from a heart failure status, where we are optimizing medications, to what we call advanced heart failure, where optimized medications are not working and have now come to the end of providing survival benefit. So how do practitioners recognize this to refer? The easiest thing to do is when a patient transitions into advanced heart failure status, it is reasonable to consider consulting an advanced heart failure specialist. An advanced heart failure specialist are part of an advanced heart failure program such as ours at Banner University Medical Center and at other institutions where these programs exist. The ways to recognize this, there are specific guidelines and information published in the literature. American College of Cardiology published its own set of criteria for how to recognize advanced heart failure. So is European Society of Cardiology published their own set of criteria. They are pretty similar in how to recognize this. I will quote here European Society of Cardiology recommendations as to how to identify a patient who transitions into advanced heart failure. For example, if the patient has an ejection fraction, left ventricular ejection fraction of less than 30%, and they are NYHA class 3 or 4, NYHA class 3 mainly, because 4 would be considered advanced heart failure status. If they have had more than one hospitalization in the past 6 months for acutely decompensated heart failure, and if they are 6-minute walk distance, it's an exercise testing that we do in the clinic, very simple test to do. If they only walk less than 300 meters in 6 minutes, and in programs where they can have a cardiopulmonary exercise testing done, and if they have what we call peak VO2 consumption, which is oxygen consumption at the peak exercise less than 12 while being treated with beta blocker, and less than 14 if they are not treated with beta blocker, if they meet all these criteria, they are in advanced heart failure. So then they should be referred to an advanced heart failure program for consideration of either transplantation or mechanical circulatory support. One of the easiest ways for physicians in the community to identify advanced heart failure patients is that, for example, if they have treated heart failure patients with these 4 pillars of treatment, despite that, patient is getting frequently hospitalized, they are developing renal failure, they are developing low blood pressure on these medications where they are either reducing the dose now or discontinuing medications. They are getting frail and progressing through NYHA class from 2 to 3 and 3B and not doing well, losing weight when there is cardiac cachexia. These are some indications where the patient is actually advancing into advanced heart failure status, and one of the best next steps for the practitioner is to refer the patient for consideration of advanced heart failure therapies, and these are heart transplantation or mechanical circulatory support. The earlier the patient is introduced to the heart failure program, the better outcomes for these patients, not only because they are able to have the advanced therapies, but also their performance and survival after transplant or mechanical circulatory support is much better compared to patients who are referred too late.
How do we at Banner Health address the heart failure issues, and what programs do we have available to our patient population and our referring physicians?
So there are several aspects that Banner University utilizes to treat this population of patients. One of the things that I want to emphasize on when you talk about guideline-directed medical therapies, in heart failure area, we consider 4 pillars of therapy. That means there are 4 distinct group of medications that every heart failure patient should be treated with, or at least an attempt has to be made to be initiated on those treatments, and then the dosing should be optimized to the best tolerated dose in every single patient. And these 4 pillars, one of them is a beta blocker therapy. Beta blockers are carvedilol, metoprolol, or bisoprolol. Those are the 3 beta blockers indicated in American College of Cardiology stage A to D heart failure patients. And this is also indicated for patients when it comes to NYHA classing. NYHA classing is a functional class of the patients. In those patients who are functional class 2 to 4, beta blocker therapy is indicated. So every single patient with the diagnosis of heart failure, irrespective of whether they are A to D and NYHA class 2 to 4, should be considered for this. Same for the other group of medication, which is called RAS, renin-angiotensin-aldosterone inhibitors. And there are 3 types of medicine: ACE inhibitors, angiotensin receptor blockers, and angiotensin receptor neprilysin inhibitor called ARNI, which is the latest medication since 2015. This is also indicated in patients who are ACC stage A to D and NYHA class 2 to 3. The third group of medicine is called mineralocorticoid antagonist, or MRA. The medication that's most commonly used is aldactone, which is indicated for similar patients with NYHA class 2 to 3. And a newest drug called SGLT2 inhibitors, which has now become very popular and considered a drug which is a paradigm-shifting drug in heart failure, should also be considered in addition to these, because all of these drugs have mortality benefit. They prolong survival of the patients with heart failure. And the two examples of an SGLT2 inhibitors that are commonly used in this country is Jardiance or Farxiga. They are also known as dapagliflozin or empagliflozin, but these four drugs should be considered. Now, how do we initiate and how do we impact the heart failure population at Banner University? There are a few things that we have organized within our program. One of them, the program is organized as a disease management program. What that means is heart failure, just like cancer and malignancy, we comprehensively manage the patient. We don't just treat the disease, but we manage the patient. What does that mean? That means we also look at other areas. For example, we look at their nutritional status. We look at frailty status. Do they need cardiac rehabilitation? We look at their obesity. Are they obese? Do they have sleep apnea? Do they have anemia? And we optimize treatments of other comorbidities, so to speak, in addition to optimizing the 4 pillars of medical therapy that just I mentioned. With regard to 4 pillars, at the Comprehensive Heart Failure Clinic at Banner University Medicine, we have resources to see these patients more frequently, as needed, immediately after discharge from the hospital. We have about 5 physicians, 5 heart failure physicians who are dedicated to heart failure. We have 5 surgeons who are dedicated to surgical therapies of heart failure. We have advanced practitioners, about 5 of them who care for patients in the inpatient setting and the outpatient setting and optimize these medications very carefully with frequent visits to the clinic. And we can accommodate patients at any time, even in a short notice, in order for them to come and get treated at Banner University Medicine. I should mention that we also have an opportunity to treat patients in our outpatient clinic with intravenous diuretics. Rather than having to go to the emergency room or getting hospitalized, we can actually treat them during the weekdays in the clinic and then bring them back the next day for evaluation and treatment if required. We have a dedicated nutritionist who works with our obese patients and undernourished patients to improve their nutrition. We have a dedicated social worker who works with our heart failure patients to make sure that they are able to afford their medications, they are able to travel from their home to the clinic, and make it easy for the patients to acquire these services that actually prolongs their life. We have a heart failure navigator who works with patients at the time of discharge to make sure that they are educated on heart failure, they are educated about medication compliance, and then they get an appointment to be followed up in our clinic within 7 days of discharge. And finally, the last but not the least, is we have our own dedicated pharmacist in our group who makes sure that every prescription that our physicians and APPs prescribe do not have any adverse reactions with other medications that these patients are already taking. So we take all precautions that's required with regard to a comprehensive management of patients in the heart failure program. In addition to the medical management, I should also emphasize that we do provide state-of-the-art advances in technology and other treatments for heart failure, including an opportunity to participate in late-breaking research activities. We have a very robust combined research projects and program in combination with the University of Arizona at our program that is actively recruiting patients for novel therapies that are not available in most institutions.
Thank you, Dr. Gopalan, for that. You have highlighted in such an important way the key benefits of a multidisciplinary cardiovascular team to manage the complexities of a patient with advanced heart failure. Dr. Gopalan, thank you for taking the time to speak with us today on Failure is Not an Option series and educating us on failure to optimize medical therapy is not an option.
Bridget, thank you so much for giving me the opportunity.
If you want to learn more about the cardiology specialists in the heart failure program available at Banner Health, please visit us at bannerhealth.com/heart for more information. Thank you for listening, and we'll see you next time on Making the Rounds.